Okay, hi. So my name is Carrie Kajewski. I'm actually the secretary for the Ontario chapter of the Canadian Federation of the Blind here today. And here's my assistant holding the mic. I wasn't sure if it was handheld or not, so I can read the Braille. She's actually my mother, and I just wanted to say that it's due to her that the reason why I need her help is that I'm a two-handed Braille reader, but it's thanks to her care that I learned Braille from such an early age, which is an important to help, in the learning process of learning Braille. So, Dr. Tom Sheidow, MD, FRCSC. Dr. Tom Sheidow is an associate professor of ophthalmology at the Ivy Eye Institute. He completed his medical training and residency in ophthalmology at the University of Western Ontario. He subsequently furthered his training with a fellowship in vitreoretinal surgery at the Barnes Retinal Institute in St. Louis, Missouri. Dr. Sheidow is very active in research and has published many articles in ophthalmology journals. He has a clinical interest in subretinal surgery, macular holes, pediatric retinal disorders, and of course, macular degeneration. In fact, Dr. Sheidow has one of the largest macular degeneration treatment practices in Canada.
Good afternoon, everybody. It's nice to see so many familiar faces, and familiar faces, both patients and people with patients. What I'd like to do, and I certainly probably won't talk about everything Mary's hinted that I'm going to talk about, because she's right. There is just so much we could do and say about what's going on in ophthalmology today as far as macular degeneration, inherited retinal diseases. It just goes on and on. But I think, like Mary, what I'd like to do for a moment is just orient everyone to what we're talking about. And when we're talking about macular degeneration, the first thing we have to realize is think back, and I think looking around the crowd, I can deduce that most of us know what a good old-fashioned camera was. When they loaded film in it, there was a lens on the front, and you could change the lens, but you put in new film. The retina, the eyeball, is very much like that. You've got a lens at the front. In fact, your cornea and your lens both do focusing. But it's the film in the back that takes the picture. And it's the film in the back that's called the retina. It transmits all the information through the optic nerve to your brain. And specifically, when we're talking about your retina and we're talking about the diseases that I'm going to go on to talk about, macular degeneration, the macula is a very small central portion of your retina. It's like the bullseye in a target, with the dead centermost portion being the fovea. And so with macular degeneration, we're talking about that portion of your retina that is at the very, very back and on the inside of your eye. It's like a bullseye. The cells are very specialized to allow you to read details, and they help do color vision. And essentially, it's important that because we're going to be talking about macular degeneration, you know about what a drusen is. When an optometrist or an ophthalmologist looks at the back of your eye and you ask them, do I have macular degeneration? They're looking for changes in your macula, and specifically they're looking for these yellow deposits called drusen. Drusen are essentially areas of waste product that have been left behind because your retinas are not as healthy as they once were, and they're not able to get rid of that waste material as effectively as they need to. And so the junk is collecting at the back. Mary had a very good slide which showed the same idea. With macular degeneration, we really do talk about the three layers that are important, being the photoreceptors that actually see the light, the pigment layer, or retinal pigment epithelial, that both acts as a barrier to prevent abnormal things from getting into your retina, but also that's the layer that does all the hard lifting. It does all the work to get rid of the junk, to get rid of the heat. Think about sitting on a beach for a day and all the heat that is generated on your skin, which when you go in, you see a nice red face or a red shoulder because you didn't put on your sunscreen. All that light's going into your eyes and is being focused, not just distributed, but focused, dead center on your retina. That's a lot of heat going in every day, every minute of every day. And your pigment epithelium, or RPE, is getting rid of that heat. And then there's the choroid. It's a blood layer underneath. It's probably one of the most vascular areas in your entire body. And so when we talk about macular degeneration, or probably what I'll do is say AMD because it's easier for me to pronounce, it's a disease of older people, plain and simple. It is not a 20-year-old's problem, it is a disease of older people. And it differs from getting older because getting older is not associated with losing your vision. People can lose their vision over time from different problems, but it is not normal to go blind as we age. Something has to happen to cause that. Before we talk about why we care, let's talk about the impact of macular degeneration, because as Mary alluded to with the inherited diseases, it's a lot bigger problem than you think. The four biggest problems, at least if you look at registries, are macular degeneration, diabetic retinopathy, glaucoma, and cataracts, something we've all heard about. If you look at the CNIB's registry, and I would put a plug in here for both their registry and Mary's for many reasons, and I'll come back to. The CNIB's registry shows that macular degeneration accounts for more than 50% of all people registered as legally blind in Canada. 50%, more than 50%. Put every other eye condition together, they don't even add up to macular degeneration, so that's why we care. The registries are important though, because the CNIB's registries and now the Foundation's registry are the tools by which we can use to leverage governments, payers, insurance companies to start paying for these diseases and doing research in them. And so it's really important that we know who has what. The World Health Organization, or WHO, also states that macular degeneration is not only the leading cause, but it's going to continue to be the leading cause of blindness in the developed world because more people are getting older. And yes, we have lots of new treatments that we'll touch on today, and Mary's touched on some other new ones. But as more people get older, more people get the disease, and we are essentially slowly but surely falling behind. Macular degeneration is about 15% of people over the age of 50. That rises to 30%, 1 in 3, over the age of 75. About 18,000 new wet cases a year, and I'll talk about what wet is. About 170 or 180,000 new cases of dry disease every year. It's a huge problem. And what it is also associated with is macular degeneration, and people with low vision in general have a much higher rate of falling, and we know that falling is associated with some severe problems in older people, triple the risk of depression, and 4 times the risk of hip fractures. And so it's not just whether you're losing your eyesight, it's all the implications that losing your eyesight can have on the rest of your life. Economically, and this is an old number, this is from 2008, $7.9 billion goes into treating people with macular degeneration and the costs associated around that. So it has big impacts. The whole process, and it's important we all realize that with any eye disease, the first thing is having a yearly assessment. If you don't go and be seen, you can't know if you have a problem. Once you do go to your optometrist or ophthalmologist, a complete eye examination is required, which requires you to have your eyes dilated. If there is suspicion of wet macular degeneration, you'll be referred on to someone who treats it, and you go from there. There's some tests we do, but I'll talk a little bit about them afterwards. So who's at risk? Getting to the topic of macular degeneration. Well, the first thing to talk about is the causes that we can change and the causes that we can't. The ones we can't change is we can't change getting older. Age is the #1 risk factor, and unless someone in here's figured it out, there's no way to change that. The lineup begins afterwards if you want to tell me how. Heredity, Mary touched on it. Yes, it's definitely a factor, but as of right now, there isn't anything we can do with knowledge of which gene causes things. It's always been believed that women get macular degeneration more than men, but that's probably because women live longer than men. And race, there is definitely a higher predilection of macular degeneration in Europeans or European descent, but there are forms of macular degeneration that are slightly different but hit all races. The alterable ones are the ones I really want you to hear. Number one by far is smoking. Number two is nutrition. I already touched on the likelihood. This has been well borne out in studies, about 1 in 3 patients. A couple of things to talk about though is with smoking, you increase your risk of developing wet macular degeneration by 3 or 4 times by smoking. And if you happen to carry the genes that we believe are responsible, that goes up by 34 times. That's a massive increase in your risk if you're smoking and you have macular degeneration. At the present time, there is no evidence that cataract surgery increases the risk of developing progressive macular degeneration. And that's important because everybody in this room, except those that have already had cataract surgery, are going to get cataracts. The only way not to get a cataract is to be unfortunate enough not to live long enough to get one. All right? So it's nice to know that cataracts are not related, but it's unfortunate that some of the big eye studies do not show any benefit to any vitamin therapy for avoiding cataracts. So along the lines of what Mary was saying, do not let somebody sell you an expensive therapy that doesn't work. Sun exposure has been up and down. They've suggested a link. They've suggested there isn't a link. At this point in time, it's not clear whether sun exposure has a clear role in the development of macular degeneration. It's always a good idea to wear a good pair of sunglasses, especially folks with macular degeneration in whom they know they have a problem. I encourage them, put your glasses on before you go outside, take them off after you come in. That sudden burst of bright light blinds you, and because your pigment cells aren't as healthy, it is much more difficult for you to recover from that insult. And so sunglasses are certainly a help. We now know that there's several different genes that contribute to the likelihood of macular degeneration, but it's not a clear cut, this gene leads to this problem. They're risk factor genes, and as of right now, these two, complement factor H and this one tyrosine 402 His, account for about 50% of the risk, we believe. But what you do with that right now is still unknown. There are genetic tests you can do. I'm not a big proponent of them because there's nothing you can do with the information. I think the safe suggestion to anyone is if you have a family history, if you have macular degeneration, even if it's early, you need to go for your yearly checkups with your optometrist, or more frequently if you have more disease. At this point in time, knowing your genes doesn't help us treat you. And so I'm not a big proponent, although it does exist. Don't want to discourage anybody who's already done it. What I do want to talk a little bit about is what's called the AREDS, or the Eye Disease Study. A very good study that was done many years ago looking at the role of beta-carotene, vitamin C and E, zinc, and copper. It was done in a lot of patients, and the bottom line from the study was it reduced the risk of progression, keyword, of macular degeneration by 25%. It did nothing for cataracts, and it was an additional vitamin on top of people who were already taking multivitamins. And so if you have macular degeneration, even if you're already on a multivitamin, you should be on one of these additional factors. The problem was back in the 90s when this study was done, something called Lutein and Zeaxanthin could not be made, pharmaceutically anyway, to be supplemented. And so it wasn't part of the study. And what I would call a problem was all of a sudden when it could be formulated, all the companies and patients were told, take lutein, it's much better for you. That's not true. We didn't know that. And we also didn't know whether more of a good thing was better. And so what happened was, it's a good product, but we need to get the answer, and so a clinical trial was done, as Mary was plugging. I would put a plug in for clinical trials too, because sometimes the answers that come out surprise you. So what happened was the eye disease study was repeated by the National Eye Institute with countless hundreds of millions of dollars spent again, but this time to look at the fish oils, the omega-3 acids, and whether adding lutein helped. Why did it matter? Well, it mattered because beta-carotene and lutein are the same family of product. They're both what we call carotenoids. And sometimes more of a good thing isn't better. We knew that the fish oils helped. But what we found out from this clear study was, number one, the fish oils or the lutein, neither were better than the formulation of vitamins we already had. So what we wanted to ask was it helpful to add them to the formulation we already have? And the answer was yes. It was helpful to add lutein, but surprisingly, if you add lutein and left in beta-carotene, it was less helpful. The beta-carotene works against the lutein. So more of a good thing wasn't better. It also showed that although the omega fish oils help by themselves against nothing, adding them did not help overall. And so if you take them for other reasons, by all means go ahead. It doesn't do any harm. But I don't recommend to my patients adding the fish oils into your current vitamin supplement for macular degeneration because it hasn't been shown to help. And for those of you who I can't convince not to stop smoking, beta-carotene increases your risk of lung cancer. By eliminating beta-carotene, you decrease that risk, and lutein does not increase the risk. And so from a safety perspective, it's also helpful. But again, none of the vitamins help with cataracts. And so we have new formulations that are out there. You can buy them at any pharmacy over the counter. There is not a prescription needed. And the new formulations have taken out the beta-carotene and the fish oils. I think it's important, though, that we emphasize one point, even if I get cut off, because I can talk forever on this topic. Macular degeneration does not lead to what I'm going to call blindness. Blindness is not being able to get down the hall and see the people in the hall and bump into the walls and bump into other people. That's not this disease. This disease will lead to total loss of your central vision. That's a big deal. And that can be legally blindness. But it almost never, I can count on one hand the number of my patients that have total blindness from macular degeneration. So don't be thinking that's where you're going, with or without treatment. There's two kinds, dry and wet. It's not whether your eyes are watering and you're using a Kleenex. This is at the back on the inside of your eye. Dry is the more common disease. It affects about 85% of people with macular degeneration, but it only accounts for 10 or 15% of those who have severe vision loss. With wet macular degeneration, it's exactly the opposite. It's only in 10 or 15% of the population, but it's 80 or 90% of the people who become legally blind. And so it's the wet form that progresses very quickly. In the dry form, what's happening is those pigment cells that Mary talked to you about are withering away. They are gradually failing, sometimes faster, sometimes slower, but there isn't anything other than the vitamins that can slow it down. The peripheral vision is always maintained, and if you want to know whether I'm going to lose all my central vision or not, the risk from dry is small, but if it's going to progress, it typically takes more than 10 years before it will progress to that point. And so it's not a quick disease. Very few people will go to 2200 or legally blind, but some do. The best way to test macular degeneration, either wet or dry, is to test one eye at a time. All right, we all have two. Thank goodness, because I made a lot of people who didn't pick up the problem in the first eye. And it's not because they weren't looking. It's because no one said, close your left eye, test the right, close your right eye, test the left. And I'm watching everybody wink at me right now. You don't have to use a grid. A grid is nice. I like anything that's reproducible. I've had patients tell me they use vertical blinds, they use telephone poles. You can use anything you like. The nice thing about a piece of graph paper is you can use it to test to make sure you're not getting blank spots, blind spots, vertical lines bending, anything like that. Because if it starts to change, it's not a matter of waiting for your next appointment. You make a next appointment sooner. The best thing you can do for low vision, well, I should say, the best thing you can do if you've lost vision from dry macular degeneration is look for a low vision assessment. There are special practitioners who offer it. The CNIB offers it. And what you're looking for is a crutch that helps you do the kinds of things you want to do to the best of your abilities. There are lots of devices that can help. I would argue, yes, none of them are perfect, but all of them help. And if you find one that helps you, great. I'm going to only touch on a couple of things. Unfortunately, Mary hinted at me telling you more than I'm going to be able to. This is one I get asked about a lot from some of my patients. It's an implantable telescope. Suffice to say, I've never seen one. They are available in some countries. I don't know that I would be recommending them to my patients at this point in time because I think they detract from what I just told you. You're never going to lose your peripheral vision. Yes, you may lose your center vision, but I'm not certain that my patients who've lost some of their center vision would be happier with one of these than not. I think counseling with these things will be hugely important. But suffice to say, they are available. They are an implantable telescope. You can't have had cataract surgery before, and there are lots of pros and cons that need to be discussed before it's an option, but they are available. Mary touched on retinal transplants or stem cell transplants. There's a difference. There is no such thing at this point in time as a retinal transplant. We have wonderfully successful corneal transplants. Remember I talked about changing the lens in the camera? We can transplant that lens. We can't substitute the film. Crumple up the film, stick it in your camera, you take a crappy picture. And unfortunately, that's the film you've got. Stem cell transplants are something different. Stem cells are, I think, the hope of dry macular degeneration. That's what I'm putting my money on, if I had to, on what will be the next best thing, but when it's coming, I do not know. We are waiting for someone to not only get cells that are viable as pigment cells, but can be implanted and survive and then do the job they need to do before the photoreceptors are dead. Because as you heard Mary say, it's harder to create photoreceptor cells. But there are people out there in lots of places working on them. I think that this is where things will go, but at this point in time, there is not even a study to point you towards. All right? And Mary was absolutely right, and I'm glad she said it so bluntly. Anything you have to pay for is not a study. All right? That does not happen. Future directions, I think what we'll be talking about in the near future before stem cells is some drugs that slow down dry macular degeneration. Some of those are in drug trials right now. Unfortunately, right now, most of them seem to be getting stuck at what we call phase 2. And so at this point in time, there's nothing I can offer anybody in the crowd here as far as a study they can enroll in. So wet macular degeneration, briefly, this is the disease that everybody hears about because it's the one that everybody hears about, the mean people sticking needles in your eye. Hopefully my patients don't think I'm mean and they keep coming back, so I use them as guinea pigs. When the new people come in, I say, when you were watching, there was trays going up and down the hall and you didn't see anybody out there crying and scared, did you? And once they realize that people weren't cowering, they realize it's not so bad. But in wet macular degeneration, that barrier layer that I was telling you about is broken down. And when the barrier breaks down, little blood vessels from the choroid, the blood layer underneath, grow up like a weed growing through the crack in the sidewalk. And that weed starts to spread and leak and bleed and takes away your vision very quickly. So as opposed to dry, almost everyone with wet will become legally blind if left untreated. And more importantly, and I emphasize this because if you are too late treating one eye, what's the most important thing I could tell you is the other eye could go. 50% of the time. Heads you win, tails you lose. It is very important that you know that, not to worry about it, but to watch for it. If your good eye starts to get worse, and you know you had wet in the other eye, don't come up with 100 reasons why it's not that. It's that. Go get it checked. So 50% of the time. Essentially, we do a test called a fluorescein angiogram. Many people in this room have had it. We inject a little dye into the veins. We take some photographs. The photos tell us if things are leaking. Anymore, that test is only done at the baseline. We don't do it a lot anymore because there's another test we use more to follow people. The test we use now is called an optical coherence tomography, or OCT. It monitors the presence of fluid in your retina, and that fluid is our goal, to get rid of it. And once we get rid of it, that test is used to monitor to make sure it doesn't come back. I want to emphasize a couple things like Mary did. Number one, everything you need to have done for your macular degeneration, if you were over 65, is covered by OHIP. Every test that needs to be done is covered by OHIP, and it's only those two, and they're both covered. Also, Both drugs that we would use to treat macular degeneration in patients over the age of 65 are covered by OHIP. There is no limit to how many you get or need. It is covered. So please don't let anybody sell you testing or drugs that you don't need. If we just briefly talk a little bit about where we've been, what the sun has set on. The sun has set on the days of laser for macular degeneration. Laser very early on in the 80s and 90s was used because it was like taking a hammer and hitting a nail. Unfortunately, not everything's a nail anymore. We have some screws too. And there was only about 10% of the population, maybe, that were even eligible for laser. And the problem with laser was 50% of the time it came right back with full force and vengeance. And so what came along just after that in 2001 was a drug called Visudyne or verteporfin. It was a light activated drug. Some of you may have had it. In fact, I know some of you have had it. The drug goes in your veins, it runs around your body for 15 minutes, it gets turned on by a laser. So it's a cold laser, not a hot laser. What it does was it stabilized things. And why I put up this curve to show people, and I do it with my general ophthalmology colleagues too, is to emphasize the curve. The curve still goes down. With Visudyne, the problem wasn't whether it worked. It's that it didn't improve people's vision, it just stopped them from getting worse as fast. So what became the dawn of the new day was that we had these things called anti-angiogenics. VEGF, or vascular endothelial growth factor, is a product in our bodies that stimulates the growth of blood vessels. And angiogenesis is the growth of blood vessels. At the beginning, I told you that macular degeneration was blood vessels growing, and so this concept of stopping blood vessels growing should help. I only briefly want to mention Pfizer and Macugen because they're the first ones that had the idea. Their drug didn't work so good. And if you'd asked me in 2005 when the drug came out, would people let me stick a needle in their eye once a month, I would have laughed at you. Obviously, I was wrong back then. What happened shortly after that, though, was the journal Nature, or Science, had this article saying Lucentis is born as one of the top 10 discoveries of the year. Eye diseases don't get that recognition. And the reason they said that was 2 studies came out in the New England Journal of Medicine where the curve wasn't going down. On average, people were gaining vision. Does that mean everybody gains vision? No. It means on an average, at least I can talk about regaining vision. And I could talk about some people having a big gain. About 30 or 40% of people gained 3 or 4 lines of vision. The secret being, the sooner you get into the treatment, the less vision you have to gain to get back towards happy. And the studies showed that this wasn't just a gain on a chart in somebody's clinical trial lab. This was a gain improving people's quality of lives. When you ask them, how are your near tasks? How are your far tasks? Your activities of daily living? They got better. So we were helping their lives, not just helping the chart. And so at the present time, the recommendation on how you initiate these drugs is you do once a month injections for 3 months, which turned my clinic into something that many people have seen before. It really is a problem. And back in the 2000s, when we started this, it was a real problem transforming a clinic to accept all the patients that needed an injection. But we figured it out, and the future moved forward, and what we started to do was try to cheat. We saw the curves in those big studies, and we said, all the bang for the buck is in the first 3 months. Maybe we can get away with less. But it's important we always remember that we want to get more before we talk about getting less. And so what I always harp on when patients start with me, especially if it's their good eye that's gone bad, about 17% of people who are not seeing a big improvement in the first 3 months will go on to have a big improvement by the end of the better part of the first year. And so if it is your better eye, we don't want to give up too soon. I'm not saying use your eye like a pincushion and continue forever. But for some folks, you've got to be patient and you've got to be hopeful because it does sometimes take a little while. The other thing we tried to do is say, okay, if we can get people good in 3 months, let's try doing it every 3 months thereafter and see if that's good enough. And so the study showed, nope, it doesn't work that way. When you go and change everybody over to every 3 months, many people regress back to where they started. And that kind of makes a little sense, at least if you ask me what I do. I like to think that I think sometimes, although at least one or two people in the audience probably don't think I think too much. But I don't want to be just injecting every 3 months because that's what we do. I want to put a little thought into it. And what the people did was they looked at the study and they said, there were some people who you could get away with that. There were some people that it didn't work in the first place, and then there was this other group. And so maybe we can't treat everybody the same. Imagine that. There's different people out there. And I also would harp on one point, that the concept and the long-term goal is not avoiding injections. Avoiding my clinic maybe, but not avoiding injections. What we're trying to do is avoid vision loss. And all you have to do is have this happen to somebody's better eye a couple of times, and you'll quickly hear why I don't stop injections on a lot of my patients. Because they have a severe bleed and it's too late. And so what you'll find is that at this point in time, we have a new drug, new one on top of the Lucentis called Eylea. They are both similar in their approach. They work slightly differently, but they are both very effective. Eylea also keeps 90 to 95% of people from losing vision and offers about 1/3 of people a big improvement. They are both good drugs. What I harp on is, and I will be done in a moment, when you ask some retina people what they want to do for their disease years ago, they said they wanted to do something called treat and extend. And the people said, but what's that? We've never tested that. Well, it turns out that treat and extend is where you treat people and try to find out how long between shots you can go safely. It's not a matter of not wanting to take you out to every 12 weeks, it's that some people can't. Your eye won't let us. And so if you spread people out slowly, you can more safely look for the happy spot. Canada being one of the places in which the volume of patients got very high, very fast, to a very limited number of physicians, i.e. my practice got overrun, we are one of the first people to adopt this. And so we did a big study, and I'm happy to say that the Canadian study of about 580 people has shown that what we're doing is we're significantly reducing the number of treatments while maintaining, and in fact, doing better than the monthly injections on vision. And so, looking to the future, there are multiple other drugs out there in trials. I think for wet, we are not looking at the transplants at this point in time. We're looking for a drug that would augment the anti-VEGFs or start to change the fact that we can't treat the scar tissue. And in essence, I think there are more, wonderful thoughts on the horizon. At the present time, there's at least 2 drugs being tested up at the IV in clinical trials, but that usually means there's several years yet before you can buy them, and it does not mean that they're better than what we currently have. But I would also, like Mary, put a plug in that there are certainly benefits to these, but you should not have to pay in a clinical trial that's being done properly. So I think Mary and I are going to welcome some questions, and you've heard me talk for long enough.